Well, I don't think it is going to be a too heated debate because we integrate all these technologies together, and of course, MRI is better. So it's going to be very easy conclusion at the end. So just to do, just because the topic is imaging, so I'm going to talk a lot about MRI, but just to review all the imaging technologies, how they evolved. I think I like to say the prostate cancer has been to dark ages in the past, and using PSA, using rectal exam to estimate, the T stage, and sampling biopsy was just a blind, biopsy, sticking needles in the prostate somewhere and hoping we got the cancer. So, and that was actually driving our histological decisions, our grading, and all treatment decisions. So very, very crude ways to assess in the prostate cancer and the risks. Just to mention some fundamental limitations of a sampling biopsy, we know there's significant undersampling, especially in large prostates. False negative rates that are very incredibly high, 30 to 80% in different series. We're missing lesions, especially in large glands, small volume tumors, tumors located on transition zones, anterior glands, and that led us to repeat biopsies, and of course that increased risks, costs, discomfort for the patients, complications, and also risk of detecting indolent cancers that add more difficulty to all this scenario. So I talked about this before. Try to individualize risks and use tools to help mitigating these risks and be a little more precise in terms of who do we offer biopsy and how do we do that better. So PSA derivatives, we use different calculations. We've been using tables, nomograms. And then in terms of imaging, a lot of different technologies came up to try to boost the ultrasound. When the transrectal ultrasound came up, we said, "Whoa, this is great." So now we're not doing blind, biopsies guided by the finger. Now we can actually see the prostate. We can put the needles where we want, and hopefully we can see the cancer. Well, that's not true. MRI, ultrasound was never really good to show us the cancer. Sometimes we can see hypoechoic areas, but still not very accurate. So many years ago, the Doppler was used trying to enhance and try to find areas in the prostate that were hypervascularized to try to guide biopsy in those areas. Was never very effective. Elastography, not sure if you guys have ever heard of this, but there's a technique when the ultrasound looks at the elasticity and how the tissue compresses, and that would suggest if there's higher cellularity or not, suggesting suspicious areas for cancer. Also never fluoresced very much. Contrast enhanced transrectal ultrasound was another attempt to improve the accuracy of an ultrasound. Even nanoparticle agents, supposedly were given better contrast and better enhancing on the ultrasound imaging by the ultrasound. Hitting those bubbles on those nanoparticles would burst and they would release the contrast agent, so that theoretically would improve the way we can see real time doing ultrasound. Didn't work so well. So and then even target biopsies using both perineal templates or transrectal templates have been tried before. The target scan is a device. I had opportunity to work with that and coordinate a clinical trial when I was a fellow at NYU, and we're just mapping and trying to use the ultrasound, the transrectal ultrasound, to direct these biopsies, and it did improve a little bit, but not significantly the accuracy of the procedure. So now, with the MRI, is a different story. Now we can localize, we can measure, we can follow these lesions, we can even assess, grade, and best of all, we can target. So multiparametric MRI has been the best advancement in this field. We can use that fusion of ultrasound to guide our biopsies. Again, I mentioned this before, it can be used not only for diagnostic purposes, but also for therapeutic purposes on the focal therapy strategies. And now we also have the molecular tests that integrate blood, urine, and tissue tests that can be all combined with all this to improve the way we do things. Just to review MRI quickly, we say multiparametric because we use different techniques. It's basically T1 and T2 weighted images. We can do diffusion weight imaging. We can do contrast enhanced dynamic phases on MRI as well. Spectroscopy has been used, but since the new PIRADS 2 version came up, and we see less and less radiologists using this. And multiparametric implies of using two or more sequences on top of a T2 weighting imaging. More recently, we see the radiologists moving towards a biparametric MRI when we have only 2 sequences. That will expedite the exam, make it shorter, will many times avoid the use of contrast and keep the same accuracy. So that's probably going to be how this is going to evolve. In terms of equipment, there's this heated debate between 3 Tesla versus 1.5 Tesla, if you needed a 3 Tesla machine or not, the use of endorectal coil. So there are different tastes and different individual approaches there. But we know that the stronger magnet improves the spatial resolution, improves the faster acquisition times, and if you have 1.5, then probably you want to have an endorectal coil there to improve your accuracy. In terms of the sequences, very quickly, the T2 is the best for morphology. We can look at anatomy, you can look at normal tissues. This is just an example how you can see the delineation of all the zones and the areas on the prostate. Very beautiful imaging, and on T2 alone you can have already a lot of information. So but you gotta be careful, because sometimes peripheral zones are heterogeneous. You can have atrophy, you can have prostatitis, and that might mislead you and towards confounding towards the cancer. The hemorrhage and also post biopsy changes in the prostate can also mimic cancer, so this is an important thing to be aware. That's why we typically don't do an MRI within 6 weeks. Ideally, you should wait 8 to 12 weeks if possible to get all those changes, resolved in the prostate before you have an MRI. So this is an example of a prostatitis giving some hypointense signal here that can be read as a cancer. So diffusing weight imaging is just a sequence that looks at how the water protons diffuse and progress among the tissues during the exam. And if they have these hindered protons that don't move so well, that implies that that area has high hypercellularity, and that's why you have changes in signal, becomes brighter in the DWI, and that will suggest the presence of cancer. If you look at this, according to different gradients, you can have maps we call the Adc maps, and that's when you have this type of reconstruction. The image is horrible, but at least you have an idea, a very, very clear contrast imaging there showing, look, this is abnormal, drop in the signal, so that's a suspicious area right there. So not examples of DWI, a T2 and DWI correlating with the specimen. So this maps and DWI has good sensitivity and specificity when combined with T2, and it can be inversely correlated with the Gleason score as well. The use of contrast is related to angiogenesis. So if you have a higher blood flow, more microvascularity density in the areas of the tumor, or even capillary leakiness, those things will actually increase signal after the use of a contrast. So this can be qualitative, semi-quantitative, quantitative. We typically use the qualitative because it's simpler, it's faster, and again you can have maps like this that become very easy, very simple to read. Talking about the spectroscopy looks at the small voxels. The voxels are 1 by 1 millimeter areas in the prostate, and then we analyze the metabolisms of the citrate choline and the choline creatinine ratio there in the tissue. So that's the normal tissue curve. That's what the signal from the spectroscopy should look like. And if you have an area that is suspicious for cancer, you have an inversion on these peaks, and that's how you read it. So you can actually map the whole prostate. So it's time consuming. It takes a little bit of a calculation to do all of this, and it has not been used so much anymore, has been phased out from the multiparametric sequences. So if you look at the PIRADS has been a great effort in terms of standardizing how MRI is read. As you see, a lot of nuances, a lot of intricacies in how do you interpret these images, so you need a very experienced radiologist. So what they've done is just standardize the way they read it, so they can talk the same language and can compare exams. This being gone through 2 versions. Second version, you can see the spectroscopy has dropped off, and this is the criteria they use for peripheral zone and transition zones, for the transition zone alone. And this is actually the key slide, and you can see that for peripheral zone lesions, your DWI is your dominant sequence. That's the only sequence you need to look basically. If you need to resolve a difference between 3, then you can use the DCE series. For tumors in the transition zone, then your T2 is your main sequence. And you can use your DWI to kind of break down any ties here around the PIRADS 3. So multiple publications. The ProFuse trial was the first randomized trial showing that if you have cognitive or target fusion biopsies, that performs better than standard biopsy. You see here the percentage of diagnosis getting better. And this is just a couple examples of how target biopsy can make diagnosis. So this is a different additional benefit of your MRI. You not only make more diagnosis, but you can use that to target and improve your biopsy. So I would argue that even if you decide that this patient needs a biopsy based on biomarkers, your MRI is going to be needed for the target fusion. So MRI is becoming the key player in all this evaluation. So in this example, we have a tumor located anterior in the prostate, was a PIRADS 4, pathology came back with a Gleason 4+3 and 3+4. Another example of a very anterior tumor, we have to stick the needles all the way up in there in the prostate, but then you can get your diagnosis, and this is confirmed on a prostatectomy as well. 15 seconds to talk about 2 trials. The PROMIS study, it's a recent study where they looked at the multiparametric MRI, assessing the need for biopsy versus doing transrectal biopsy in all these patients. And as you can see, when you use the multiparametric MRI to decide if they need biopsy or not, you make a lot of diagnosis among the ones that were called significant, and among the patients that we call non-significant on MRI, you're missing very few significant cancers there. So it enhances your ability to make that call. Precision study came up in May 2018, New England Journal. Everybody's talking a lot about this study too. So very briefly, they used MRI to decide if patients need to be biopsy or not versus just doing a standard biopsy on everyone. So in this group, we're calling MRI targeted. And you see how that shift the difference in terms of a detection and any type of analysis that was done here. Looking at the PIRADS V2 scores, the ones that were called PIRADS 3, 4, and 5, you see the breakdown on significant cancers that were detected. So again, supporting that patients benefit from target biopsy. So again, MRI and target biopsies are, they detect cancers accurately. They can detect index lesion in 90% of the cases. We're still saying, until precision came up, we were saying that we still needed to sample and do biopsies in the whole prostate. This study came out showing that that may not be true. We're actually having enough diagnosis sampling targeting just the lesion. This is debatable. But as a biomarker, I think MRI is not only having a central position, but also earlier position in the timeline. And I think this is a rapidly evolving field, several new tests coming to market. We just need to keep the focus on the personalized medicine, individualized care for the best of our patients.